Hello everyone, welcome back to Tutor Series. My name is Shujauddin and in today's session we're going to talk about focal segmental glomerulosclerosis or FSGS. So what is FSGS? Consider focal segmental glomerulosclerosis to be a sort of a advanced disease that is progressing from minimal chain disease. Now minimal chain disease had a really good prognosis, but if I were to advance minimal chain disease, so I would end up with focal segmental glomerulosclerosis. Now, this is a really huge name, so let's understand this name first before we go on to the associations, clinical features, and the morphology. So let's break it and understand it. So when I say focal, let's say we have a kidney and that kidney has nephrons. Nephrons are the basic functional unit that are present in the kidney, right? So let's say a kidney has 100 nephrons. 100 nephrons would mean having 100 glomerulus, right? 100 glomeruli basically. So in those 100 glomeruli, let's say you have pathology in 20 of them. That would mean focal. Not all glomeruli are being involved, but a few glomeruli are being involved. So that would mean that it is focal in nature, that it's affecting a few glomeruli, right? So that is what focal stands for. Now coming on to segmental. What do I mean by segmental? By segmental, I mean that the 20 glomeruli that were being affected by this disease, in those 20 glomeruli, not the whole glomeruli, but a part of that glomeruli is being involved in the pathology, right? So by focal, I meant not all glomeruli, but a few glomeruli, and in those affected glomeruli, just a certain area of that glomeruli is involved in the pathology. So that is what I mean by focal and segmental. Now coming on to glomerulosclerosis. So glomerular means that the disease is happening in the glomerulus, and there is sclerosis in the glomerulus, that is deposition of your matrix. That we'll see how that happens. So this is what I mean by FSGS, focal segmental glomerulosclerosis. It is kind of an advanced version of minimal change disease, so you can call it that. Now it comes under the heading of nephrotic syndrome. So it is a type of nephrotic syndrome. Let's talk about the associations, that how can a person get FSGS. So the first association being idiopathic. So the disease could be idiopathic in nature. But if it is to be secondary, what would be the associations in that? So the first one being patients who have HIV are at risk of developing FSGS. Patients who have sickle cell disease are at risk of developing FSGS. Apart from that, patients who are Africans, the African community is at risk of developing FSGS. Patients who are heroin addicts, they are at risk of developing it as well. Apart from that, if you have renal scarring due to any reason, you had a disease, you had pyelonephritis, anything, if you have renal scarring, on that renal scarring there are chances that you can end up with FSGS. So any pre-existing renal scarring will be a risk factor. Apart from this, if you have renal agenesis, if you have renal ablation, if you have reflux nephropathy, all of these are risk factors of developing FSGS. So renal agenesis, ablation, and reflux nephropathy. Now these could be the associations that can lead to FSGS. So these are really important to know. Now what happens in FSGS is, like any other nephrotic syndrome disease, in FSGS you have effacement of your podocytes, right? You have damage to your visceral cells. So basically podocytes are also called visceral epithelial cells. So damage to your visceral epithelial cells or podocytes is what happens in FSGS, and that is basically what happens in all nephrotic syndromes. So that is going to happen. Now due to damage to your podocytes, what's going to happen is that you will also have sclerosis. That is, your mesangial cells, they are going to increase the deposition of your matrix. When you have increased deposition of your matrix, you will end up with sclerosis and hyalinosis. These two things are going to be deposited inside your glomerulus. So two things, that is hyalinosis plus sclerosis. These two things are going to happen in FSGS. So this is due to increased deposition of your matrix. Now, after these associations, let's talk about the clinical features, that what would happen in FSGS, what would a patient come across. So the first thing would be that the patient will have hypertension. we did not have hypertension in minimal chain disease, but we do have it in FSGS. Like I said, FSGS is considered to be the severe form of minimal chain disease, so you will have all of these things. Apart from hypertension, you can also have hematuria. Yes, I know you guys might be wondering that in nephrotic syndrome we don't have hematuria, but in severe cases of FSGS you can have hematuria. So you'll have hematuria. You will also have reduced GFR. Your glomerular filtration rate is going to decrease. So reduced GFR would be something that you will notice on FSGS. Apart from reduced GFR, you will also see that the patient of FSGS will also have they won't respond to steroids. Minimal chain disease was responding to steroids, but no response to steroids. So you won't have any response to steroids. Apart from this, there are chances that patients of FSGS can progress to chronic renal disease. So we have different chronic renal disease. We also have renal failure, so a patient can progress to that. And since it is in nephrotic syndrome, you will have proteinuria. That is something that you need to remember, that you will have proteinuria, but the proteinuria is going to be different from what we had in minimal chain disease. Now, how would it be different? The proteinuria that happens in FSGS is going to be non-selective in nature. Now, do you know the difference that we had in minimal chain disease? In minimal chain disease, the proteinuria was selective. It wasn't non-selective. That is, you just had albumin leaking out, not the globulins, nothing else. But in FSGS, the proteinuria is going to be non-selective. That is, you will have loss of albumin, loss of globulins. All of the proteins are going to get released. So I hope that through the clinical features, you can notice that the patient is very much different from minimal chain disease, and it's kind of a bit severe presentation compared to MCD. Now, coming on to the morphology, that on morphology, what would you see? The difference would be that you can notice FSGS on light microscopy. It's very much visible, while minimal chain disease were not visible on light microscopy. So you can see it on light microscopy. I'll write it here that it's visible. Now, what would you see on light microscopy in a patient of FSGS? So what you're going to see is that you will have a few glomerulus. You will see the pathology on in a few glomeruli. So minority of glomeruli are going to be involved. Now, in that minority of glomeruli, what would you see? You will see three things. The first one would be that you will have collapse of your capillary loops. Apart from collapse of your capillary loops, you will have matrix deposition. You will have matrix deposition, you will have sclerosis, and you will have hyalinosis. So these are the three things that you will be able to appreciate on light microscopy. But when you look at the glomerulus on light microscopy, you'll see that you will have normal glomeruli and also damaged glomeruli. But you can see it on light microscopy. Now coming on to electron microscopy, that what would you see on electron microscopy? On electron microscopy, the areas that are sclerotic and the areas that are normal, they're both going to show one thing, that is going to be effacement of your podocytes. Keep in mind, I just said that on electron microscopy, the normal glomerulus and the abnormal glomerulus, they're both going to show a common thing, that is effacement of your podocytes. So this is something that you will have to see, and you will obviously have sclerosis and everything that would be present in FSGS. Now coming on to immunofluorescence. Now there's a bit of a debate on immunofluorescence, that will you see anything on immunofluorescence or not. So a few books say that you won't have any immune complex deposition and you will not see anything on immunofluorescence, but a few resources do say that you might be able to appreciate IgM and C3, that is a complement factor, on immunofluorescence. So that's up to you whether you go for which resource, but keep in mind that you have minimal immunofluorescence present. If it is present, it would be IgM and C3, or you won't have any immunofluorescence. So it's either going to be none, or it would be IgM and C3. if it's present. So like I mentioned in my video on nephritic versus nephrotic syndrome, that light microscopy, electron microscopy, and immunofluorescence are the three things that you do when a patient comes to you with nephrotic or nephritic syndrome. So this is what you're going to see on these three things. Now, one subtype that you need to know of that is present in FSGS is that it's collapsing glomerulopathy. It is a subtype of FSGS. It is basically a much more severe condition. Now what happens in collapsing glomerulopathy is that, as the name suggests, you have complete collapse of your glomerulus, right? So you will have complete collapse. Now this complete collapse could be either idiopathic in nature, or it could be due to patients who have HIV or patients who consume pamidronate, which is basically a drug. So complete collapse of your glomerulus. And one thing that you would see in this is that with the complete collapse, you will have hypertrophy of your podocytes. Hypertrophy of your podocytes. So these two things would be appreciated on morphology. And like I mentioned, I'll just mention it here, that it is either idiopathic in nature, or it could be due to patients who are suffering from HIV or who consume pamidronate, which is basically a drug. Right, so you can have that. Now, one thing to notice is that if in FSGS you have no response to steroids, like I mentioned here. So FSGS is basically really difficult to treat, and it has really severe clinical features. So in patients who have FSGS, they might progress to renal failure, they might not survive. But it has been noticed that if a child is suffering from FSGS compared to an adult, so a child will have a much better prognosis rather than an adult. So this is something that has been noticed on multiple studies. So just telling you guys that a child might have a better chances of surviving FSGS rather than an adult. So in this video we talked about the different associations that you might have with FSGS. A few of these associations are really common, that is patients who have HIV, sickle cell, African in nature, or who are heroin addicts. These few associations are really common because these people do end up developing FSGS. Now in FSGS, I mentioned that you have hyalinosis and sclerosis. The clinical features, we have gone through that, and the morphology, try to compare it with the minimal chain disease. That is, on MCD you have nothing on light microscopy, but you have a lot of things visible on light microscopy. On electron microscopy you will have effacement of podocytes completely. Whether the glomerulus is involved or not, you will have diffuse effacement of podocytes. On immunofluorescence you might see nothing, or if you were to see anything, it would be IgM and C3 combination. And a subtype that we discussed is collapsing glomerulopathy, in which you have complete collapse of your glomerulus. So I hope that we briefly talked about FSGS and it was clear to you. If you have any questions, feel free to write them down in the comment section or reach out to us on our Facebook page. Thank you so much for watching.